So today, the purpose now, if we think about the pipeline of our idea to publication, we've planned the study, we've put together a grant proposal, we got funding, we've performed the study, we made sure everyone did it well, we made sure that we've done data quality and locked our database. So now we're at the phase where we're going to be analyzing our results. So as Dr. Ramirez said earlier this morning, there's 4 possibilities that explain our study results. And that's truth, confounding, bias, and chance. And hopefully we got across earlier this morning that when we're planning the study, we are trying to minimize confounding and bias. Now, that doesn't mean that you won't find confounding and bias later, but the goal is to try and minimize these, or at least plan for them when you're planning your study. So then truth, as Dr. Ramirez said, is that the conclusion we reached from our study matches reality. So let's say that we have our study hypothesis and then we turn that into a alternative hypothesis through the process. Then if our study results match up with what is actually true, we have true results. We could also have results that we find due to confounding. So as Thomas mentioned a little earlier when talking about databases, or not databases, study variables, confounder variables are those that affect both the predictor and the outcome, and then may possibly change the effect that you have on the predictor and the outcome. And so there's essentially 2 types of confounders. There's known confounders and unknown confounders. So known confounders are things that you're going to plan and account for, and unknown confounders are things that, as Thomas said, there's an infinite number of variables that exist in the universe. There are going to be some things that impact your study that you don't know about. And that's why randomization is such a powerful tool to minimize the effect of confounding, because it's the only way to account for confounders you don't know about. Your study results could also be due to bias. So I've listed a couple different types of bias here, but there are numerous amounts of bias that could happen when performing a study. So the first type of bias that I want to talk about is measurement bias, which is that different instruments may measure things differently. So for example, in pneumonia, we use the presence of pulmonary infiltrate, so lung, gunk in your lungs, to be an inclusion criteria for pneumonia, as opposed to a different type of respiratory illness. Now, there are 2 different types of imaging most commonly used. So there are CT scans and chest x-rays. And sometimes they don't agree. So if they don't agree and you are using one or the other, you could potentially be missing inclusion criteria for a patient, or you could be including a patient incorrectly. Interviewer bias refers to when different researchers are going to collect information differently. So as Dr. Carrico just spent the last 30 minutes or so telling us about the importance of training and having a standard operations and uniformity, that is essentially interviewer bias we're trying to minimize. So the term actually originates from when people would do interviews with patients, and then so perhaps the interviewer knew something about the patient and would, instead of asking, do you smoke or do you drink, they might say, are you sure you don't smoke? To try and elicit an answer differently. So, but interviewer bias can take many different forms. So if you have people who aren't following the same standard operating procedure, then you could potentially be having interviewer bias in your study. Recall bias is a bias that's possible when you are eliciting information from your patients. So for example, if you ask, when were you vaccinated? If they say they've been vaccinated, perhaps they give you the wrong year. We've done studies actually about how patients generally don't remember very well when they were vaccinated by checking against their insurance records and the EMR. And then there's also chronology bias, which is that things change over time. And if you don't account for that, then you may have your results due to just those changes over time as opposed to the study itself. So if you're doing a retrospective study, of all community-acquired pneumonia cases over the past 20 years, then it would be an important idea to include time inside your study as a variable, just because the management of pneumonia has changed over the past 20 years. And then finally, we have our study results being due to chance. And what this typically refers to is that we had some kind of error. And I'll discuss the type 1 and 2 error here more in a second. So then, because of the random variation that exists, remember that not every patient's going to experience the same outcome. They're going to have different experiences. Our sample population is going to differ from our target population. So then statistical tests are used to estimate the effects of that random variation and to predict how likely the results are in the sample that we collected. So what that means is that we're going to do what's often called null hypothesis significance testing. And so ultimately what that means is that we need to reframe our research question into a hypothesis and then another hypothesis. So we're going to have the study hypothesis and a null hypothesis. And the reason we do this is because it's very difficult to prove something is true, but it's much easier to show that something is very, very unlikely. So if you think of the term innocent until proven guilty, that's kind of how we treat statistical tests as statisticians. So here, we can only use statistical tests to prove, or not prove, but show that hypotheses are probably false. So what's going to happen is that we're going to have our research question, and then that's going to produce a study hypothesis. So let's say our research question is, we think low-dose corticosteroids are going to improve patient outcomes with COVID pneumonia. So then our study hypothesis is going to be reframed so that we say, we think patients on corticosteroids will improve by 10%. So then we form an alternative hypothesis and a null hypothesis. And so the null hypothesis then is going to be a statement that we are assuming is true until we've gathered enough statistical evidence to prove it false. So when we do null hypothesis significance testing, we're going to be converting the data that we have into a test statistic, which is going to follow a distribution and then yield a p-value. And for time, I can't get into the exact science or statistics of that, just because there's lots of different types of analysis, but we will spend a little bit of time talking about p-values. However, you can think of this that there's the rejection rule. So remember, in statistics, a hypothesis can never be accepted. It can only be rejected. So then, I've already stated that, but the null hypothesis, again, assuming there is no association or no effect. And you can think that there is a parallel here between diagnostic testing and the statistical hypothesis testing. So let's say that we are using a screening test for HIV. Now, HIV is a very significant disease that could have life-altering consequences for a patient. So it's important that we don't want to incorrectly ascertain the results of this test. So we want our test to be positive when they have the disease. We want it to be negative when they don't have the disease. Anything else would be an error. So in the same way, if we think about the reality of our research hypothesis, we have whether or not the hypothesis is true and whether or not the hypothesis is false in reality. Now, our study results can be positive or negative, independent of whatever reality is. And so what we want to see is a study result that's positive when our hypothesis, our study hypothesis is true, and negative when our study hypothesis is false. However, we could be making type 1 or type 2 error. And so if random chance leads us to the mistaken conclusion that there was an effect, that's going to be type 1 error. So you can think of that like a false positive for a diagnostic test. And if it leads us to the mistaken conclusion that there was no effect, that's a type 2 error, and you can think of that as a false negative. So it's very similar to a diagnostic test in that regard. And as Thomas mentioned earlier when we were talking about sample size, we're going to establish the type 1 and type 2 error rates prior to performing the study. And these are commonly held at 5% and 20%, but that doesn't mean that's always the case. So another thing, or another way you can call type 1 error is by alpha, which is generally also considered your level of significance. And so almost all studies that are published, and there are exceptions to this, have a 5% type 1 error rate. Some studies choose to have a more strict type 1 error rate, so they might use 1%. And what that means is that when they are doing null hypothesis significance testing, they would use a lower threshold for determining statistical significance. And then type 2 error, or beta, is the probability that we would not find an association when there is one. And so typically we hold beta to be 20%. And so what that means is if we think of the power of a test, the power refers to the probability that we would correctly find an association or an effect there. So the power is just 1 minus our beta. So if we have a 20% type 2 error rate, that means that we have 80% power to detect a difference. So then, as I was saying earlier, when we have our study results that we get, we're going to take our data, put it into a test statistic, and then find a p-value. So then the p-value is the measure of effect of chance within our study. The p-value is not the probability that our study is correct or that our study is true. So strictly speaking, the p-value would be that if the null hypothesis were true and we had no bias, we had no confounding, then we would see results as extreme or more extreme. And the reason I say that is because the test statistic is what determines the results we found. So that corresponds to if we were to see an even larger measure of effect or an even larger association. So when I say that extreme or more extreme, just know that that's what I'm referring to there. And so a p-value, unfortunately, doesn't tell us anything about what we're actually interested in for the study. So our research question is usually, do corticosteroids improve patient outcomes? The p-value doesn't say, yes, corticosteroids improve patient outcomes. And we, truth be told, can't know that from a single study. So it's always important to look at your results with that in mind. So just because you have a significant p-value, that doesn't necessarily mean that your study results may be clinically meaningful. And so we're going to discuss that more later today. And one thing that's very important, and I propose would be something more useful, clinically speaking, would be to look at confidence intervals. So what a confidence interval does is it's a way of describing that magnitude of effect or the effect size that exists from your results of the study. But then it gives you an amount of variation to say, if we were to repeatedly do this study, we would expect to find our association somewhere in these lines. So a confidence interval gives you a better idea of the true effect of your study. So to conclude, there's only 4 possible explanations for the results that you see in a study. You have truth, bias, confounding, and chance. And in research, truth, proof, and evidence are all human concepts. We take things that we observe and then we make conclusions about them. But truth never comes from a single piece of evidence or a single p-value. As much as Dr. Carrico has talked us up as statisticians, the p-value is not some gift from on high that is, blessing your study. So that the truth and knowledge that we have comes from an accumulation of research over time. And so, yeah. So now Thomas, or actually we have a break, don't we? So anyway, thank you all.